Teşekkür ederim. Herkese günaydın.
Thank you and good morning. I also would like to thank the organizing committee for giving us the chance to be here together today. This whole session will be focused on personalized medicine and tailored treatments in psychiatry. So let me start with a definition of personalized medicine. Personalized medicine has the possibility to predict those patients who are likely to have a desired response to the drug and who are likely to have a benefit. Let's have a look at the historical development of personalized medicine. It started off with dose personalization back in the 15th and the 16th centuries. Even back then, some experts had opinions about personalizing the dosage of different medicines. Then William Osler said, "The good physician treats the disease, the great physician treats the patient who has the disease." This was a saying from the 19th century. Therefore, this was a very important saying about personalized medicine. When we treat our patients, actually this logo represents the patient, by the way. When we treat the patient, we give the patient the therapy, the patient heals. We give another the treatment to the patient does not heal, or the therapy can lead to toxic effects. So patients with the same diagnosis receive the same treatment, and some of them are healed and some of them do not get any better. Only then the physician started thinking that this might be because of personal differences in between patients, and this is what led us to think about personalized medicine. Here you see a group of patients with the same diagnosis. So our classical therapy as of today is to consider all patients with the same diagnosis the same. But genetically, all these patients have differences. They're not all the same. Or at least due to environmental factors, they can be differentiated from one another. When we look at this group of patients, a very large majority of them responds to our standard therapy. It depends on the population and it depends on the drug as well, but 80% of all the patients respond to our therapy. However, for all diseases, there is another group that makes up at least 20% of the total patient population that does not respond to therapy. And here again we have patients on this slide. These are patients with the same disease. We administer a drug, and based on their genetic factors and environmental factors, some of the patients benefit from the drug. So the drug is safe and effective in a majority of the patients. In a smaller group of patients, the drug is safe, but it's not effective. Therefore, it doesn't matter if they take the drug or not. In an even smaller group, the drug is not safe and not effective. There are side effects. And here in this group, the drug is effective, but this time it has some toxic effects as well, so it's not safe. What is the objective of personalized medicine? To reach a good diagnosis based on personal features and to carry out a good, efficient, favorable treatment. So to give the right drug to the right person at the desired dose. This is the overall target of personalized medicine. The main theory behind this type of medicine is that each individual is unique. And due to their unique characteristics, they should receive different therapies. The therapy should be personalized. So personalized treatment has certain characteristics and tools that we make use of. Genetic alterations, for example, have an impact on personalized medicine, as well as epigenetic modifications and environmental factors. As a pharmacologist, I have to show you this slide. Pharmacology has two dimensions, as you know, pharmacodynamic and pharmacokinetic. I have to show you this slide because during the journey of a drug within the body, there are genetic factors and environmental factors in place which have an impact on the pharmacodynamic and pharmacokinetic qualities of the medicine. Pharmacokinetic refers to absorption, distribution, metabolism, and excretion, and pharmacodynamics of the drug has to do with the efficacy of the drug and the active molecules. What are the techniques that we benefit from in personalized medicine? Well, first of all, genotyping is very important. That is the genetic factors. And then phenotyping. Phenotyping is the interaction between the genetic composition and environmental factors. And of course, we make use of TDM as well. These are the instruments that we use to personalize the treatments. Which patient populations may predominantly benefit from personalized medicine? Of course, the ideal case would be a society in which all patients receive a personalized medicine, but there is a specific patient population too that should predominantly receive personalized medicine, such as children, pregnant women, elderly patients, and those people who have somatic or psychic disorders or diseases. Criminals also require personalized medicine, and those patients, for example, who we know have a different genetic susceptibility or composition. In psychiatry, around 130 drugs have become available in the last 60 years. Out of these 130 drugs contributed significantly to our treatment strategies in psychiatric disorders. However, we have to accept the fact that only 50% of the patients can be treated with these medications in a safe and effective manner. The rest of the patients either have a high side effect profile or the drug is not efficacious on these patients. Looking into the reasons of this lack of success, we see that there are genetic factors that have an impact on our overall success rate. For the personalization of the therapy, we have to check the serum drug levels in the patient, and we carry out genotyping and phenotyping as well. And on the basis of the data that we derive from these tests, we individualize the therapy. Therapeutic drug monitoring is about the drug levels in the serum. So we want the drug to be within the therapeutic window. This is actually the very foundation of psychopharmacotherapy, because if it is below the window, then it's not efficacious. If it's above the window, then it can become toxic. Therefore, this is a basic routine test that we run on all inpatients. Gökben will give you even further information about therapeutic drug monitoring, so I will not go into the details. Another tool that we use often is phenotyping. Here we're talking about different characteristics that came into play as a result of the interaction between genetic qualities and environmental factors. Genotyping has to do with differences stemming from one's genetic features, and this has an impact on response to therapy. Therefore, in genotyping, we benefit from some pharmacogenetic and pharmacokinetic parameters. However, of course, both the literature and the lab tests that we can run are limited. We can, of course, test the CYP enzymes pharmacogenetically, and pharmacokinetically we can test the 5-hydroxytryptamine. Korkut will give you further details about these tests. Let me show you a couple of slides to explain to you the importance of personalized therapy. CYP2D6 is the most important enzyme here. Sometimes it can become an metabolizer. It functions very rapidly, therefore it might reduce the plasma levels of some of the drugs. Here you see different duplications for CYP2D6 gene. So there should be one allele actually, but some patients have 2 to 13 alleles. Some individuals have 2 to 13 alleles. This, of course, has an impact on the plasma concentration level of the drug. For example, here you see a plasma concentration slide for nortriptyline. If an individual has 13 alleles of CYP2D6, then the plasma concentration level stands at around 10. And those who do not have this allele at all, it has a plasma concentration of 55. So the individualized difference in between these two patients is almost 6-fold. Let me share with you a case study to support the data that I've presented so far. This was presented in the Turkish Clinic's Journal of Case Reports. It has been recently published. In this patient, we ran all the tests, genotyping, phenotyping, and TDM. This is a 25-year-old man hospitalized for psychosis. His body weight is 75 kilograms, and he's 175 centimeters in height. He receives a tripartite therapy. You have 3 more minutes, Esra. So the patient receives 30 milligrams per day of mirtazapine, 20 milligrams of paroxetine, and 6 milligrams of paliperidone per day. But the plasma concentration levels are very low for all 3 drugs. The metabolizing enzymes for these drugs, for example, CYP2D6 and CYP3A4 are the common enzymes for mirtazapine and paroxetine. Therefore, one of these two enzymes might be functioning far too rapidly. For paliperidone, actually, 60% of paliperidone is not metabolized. The remaining 40% is metabolized through different ways. But recent publications showed that these several pathways are a bit more specific to CYP2D6, and we have some idea about a possible rapid functioning of the patient's CYP2D6 anyway. The patient is resistant to therapy and his blood concentration levels are very low, so we did genotyping on this patient for the CYP enzymes. The genetic test for the CYP enzymes showed us that only CYP2C19 turned out to be an ultra-rapid metabolizer. We expected CYP2D6 to turn out to be the rapid metabolizer, but it wasn't so. It was found to be an extensive metabolizer, which is a normal result. The literature, as suggested by the literature, we continued with phenotyping on this patient. We did the phenotyping for CYP2D6, and the genotyping appeared to be normal. He was a normal metabolizer, but the phenotyping showed us that CYP2D6 was found to be an alter metabolizer. Why is there such a difference between genotyping and phenotyping? There might be several reasons behind this. Environmental factors, smoking, drug-drug interaction, any of these factors might be effective. We also looked at this serotonin receptor transporter protein because the patient did not respond to therapy. but both alleles were long, so the patient was normal. So we used these 3 parameters and individualized the therapy of this patient. So in the discussion, here's what we say. Yes, TDM follow-up is definitely important, especially in psychiatric patients who are refractory. If a patient has abnormal TDM, then genotyping is the golden standard, according to literature, the gold standard. If there is any mismatch between genotyping and TDM, then we might consider that this stems from environmental factors. That is why we should carry out phenotyping. When these 3 tests are done one after the other, we can easily individualize the therapy of the patient. We have to keep in mind that when we do the genetic test for CYP2D6, we can check all the SNPs, all the SNPs. There might be some SNPs that we weren't able to detect, for example, and maybe genetically we could have seen that CYP2D6 was a rapid metabolizer, but we couldn't test for that SNP apparently. But phenotyping helped us to overcome this deficiency. Thank you for your attention.